Good afternoon. We're glad you're here to join us for the webinar on Cancer 101. We're going to pause for just a minute so that people can get into the webinar.
You are rocking the data.
Okay, good afternoon. I'm Megan Ressler from Mayo Clinic in Rochester, Minnesota, working in the Cancer Education Center. We're bringing a webinar to you today titled Cancer 101, The Basics. And my colleagues that I work with are the people that are presenting this webinar. So we have Janine Kokel, Tara Register, Gina Lang, and Brandon Lee. They'll do some introductions of themselves. We just want people to know that this session is being recorded so that individuals that aren't able to join us for the live session are able to watch this at a later point in time. We encourage you to like our cancer education blog on Mayo Clinic Connect so you can stay up to date with webinars that we'll be offering. This will be the last one for 2021, and then we'll have new ones coming to you in 2022. We will also allow time for question and answers. So if you want to ask a question, you can type that into the chat box in the question and answer area. And we'll do our best to try to answer any questions that you may have. So with that, I'm going to go ahead and turn it over to my colleagues and let them do their introductions.
Okay, thank you, Megan. I'm Janine Kokel, and I'm one of the educators here in the Mayo Clinic Cancer Education Program in Rochester, Minnesota. All of my colleagues here speaking today are working within the Cancer Education Program here in Rochester. And so my background is nursing, and I work as a patient educator. Thank you. I'll turn it over to Tara.
Hi, everyone. My name is Tara Register. I am a registered nurse and I am a patient educator alongside with my other colleagues here at Janine. And I do have a background in nursing as well. And we'll let Brandon introduce himself.
Hi, everyone. My name is Brandon Lee, and I am one of the patient navigators here at the Mayo Clinic Cancer Center in Rochester. My background is in radiation therapy.
And then I think I'll introduce our colleague Gina Lang. She's having some technical difficulties with her computer, but she'll be joining us very shortly. But Gina Lang is an oncology nurse as well, has worked for many years in hematology, but now is a cancer patient educator as well. So I think what we'll do is go ahead and get started. So Tara, Gina, Brandon, and I have worked in a variety of oncology roles and are very passionate about oncology cancer care. You know, we thought it would be maybe nice to share just a brief introduction and overview of what cancer is, how it develops and how it behaves, some of the known causes, how cancers are named, how it's treated, and some common terminology you often hear about it. Next slide. Cancer is often thought of as a single disease. We often are asked, when are they going to find a cure for cancer? Or how and when are they going to get that cure for cancer? And oh, how I wish there was an easy answer and solution to that question. Unfortunately, it's not so easy to do. Cancer is not just one disease. There are many types of cancer, probably well over 200 different types of cancers. And within those types of cancers, there are subtypes of cancers. There are different cancers, all of these different cancers that occur in us humans also have, who have different hereditary makeup. We have different lifestyles and habits, different lifetime exposures to potentially harmful chemicals. And people often just have different responses to medications and different treatments. Some cancers can be very aggressive, fast growing. Some are less aggressive and very slow growing. Some are found early on, and some are found when the cancer is very advanced or in advanced stages. Cancers are alike in some ways, in that they all begin within changes that happen and alter in the baselines of our cells, in the DNA or genes of our normal cells. But cancers are also So very different from each other in the way that they grow or spread or react to treatments. Normal cells become cancer cells largely because of alterations, changes, mutations in these genes, in our genes. Some of those mutations are inherited, present at birth, and some never cause any problems at all, and some can, but most are acquired. We acquire them sometime over our lifetime. Often, many alterations and mutations are needed before a normal cell becomes a cancer cell. Many types of cancers will have a whole variety of these mutations within them. Mutations are just abnormal changes in that DNA of the genes. Cancer cells continue, though, to change and alter and mutate again and again over time. So it's a little bit like trying to treat a moving target. Some cancers can have well over 100 mutations. Some of those mutations, like I was saying, don't cause any problems at all. But some will cause that cancer to grow and keep growing. And it can be very difficult to sort out which of those mutations are the ones causing that cancer to grow, and then to figure out some way to develop a drug or some process to stop that specific thing from happening within the cell that's allowing that cancer to grow. All of these factors really can contribute and complicate the ability to treat cancer. Plus, cancer is pretty dang smart, and cancers can learn how to adapt or grow and often survive against different kinds of things that we do to treat it and throw at it. Excuse me. Cancer is a general term that refers to abnormal malignant cell growth. Normal cells, for many reasons, some we know and many we don't, can ever so gradually, subtly start to transition and change to those more abnormal cells. And over time, they become more and more abnormal, and they mutate and they transition, and then before they become these malignant cancer cells. This process at times can happen fairly quickly, but many times it can take years for that process to happen. So the key is trying to find these things early on. To understand how cancer develops, it's helpful really to understand the difference between normal cells and these abnormal cancer cells. The average human body has over 37 trillion cells that make it up. Those cells, along with a lot of water and specific elements, provide the structure for our body. They take in the nutrients from our food, and they convert those nutrients into our energy and carry out these specialized functions that they have. All these cells funnel down to about 200 different types of cells. You know, we have hair cells, skin cells, brain cells, lung cells, muscle cells, blood cells, and they all have a specific job to do. You know, it's hard to even imagine what is a trillion cells like. So for comparison, I like to relate that to some aspect of time. So if you do a Google search, you can figure this out too, or see 1 million seconds ago. So 1 million seconds ago is about 11.5 days in time. 1 billion seconds ago was about 32 years ago. And 1 trillion seconds ago was about 32,000 years ago. So it gives you a little idea of how many cells that we have in our body. All those cells, as I was saying, have a very specific job to do. They're smart. They know what they're supposed to do. They know when they're supposed to do their job. They know when they're supposed to sort of chill out and wait until their job is needed. Normal cells follow, they divide and grow and multiply, I guess, in a nice, neat, orderly way. They follow very specific rules and regulations and instructions from those DNA in our genes. When they're worn out or damaged for some reason, they put in place a process to divide themselves and make a brand new, strong, healthy copy of that cell to go out and be strong and take over, while the old cell dies off and our body filters out that debris. That happens all the time. Cells are constantly dying and new ones are being made simultaneously. Normal cells replace themselves, one cell for one cell. Billions of cells are made this way every single day. No wonder we're tired by the end of the day. Our bodies are working very hard at a cellular level. There are many check and balance systems within this complex bodies of ours that are always on surveillance and looking for things that shouldn't be there or that may be coded wrong, developed wrong. But cancer is pretty smart and sneakily, and it can learn ways to evade some of those surveillance check and balance systems and become troublemakers because our bodies don't recognize it as foreign and don't recognize to go get it. Cancer cells don't follow those rules and regulations. So cancer cells keep growing and making new cells. They forget to die and they start to accumulate on top of each other. They can crowd out their neighbors and normal cells, and they can start to invade their neighbors. Now, they're very smart. They're programmed to survive. They can send out signals to the body as they get a little bit bigger and become a little bit of a lump, so to speak. They can say, hey, body, build me a capillary system to nourish myself. They can learn how to develop new pathways to get around some of those treatments that we're doing, trying to block it. They can tell the body to develop sort of a protective sort of barrier or coating, so to speak, around them to kind of keep them hidden from the search and destroyer cells that are always looking to get rid of those bad cells. So our bodies just don't recognize and attack those cancer cells. Cancer cells are also extremely small. Now, several of the oncologists I work here have told me that about 1 million cancer cells could fit into the space just a hair bigger than where one strawberry seed would fit on a strawberry. So that's pretty amazing. It's not like we can, scan the body all the time looking for these things because we can't see them until they become bigger and problematic. The human body is pretty darn miraculous when you think about all that's happening. Next slide, please. So I guess this is just to also recap that normal cells have a very specific job to do. They follow the instructions of the genes in each cell. They live a normal life and they know to die off, and they replace themselves one cell for one cell. They stay in place. They don't travel to other parts of the body. They don't damage or cause problems to their neighbors. But cancer cells quit doing their job. They get damage in the DNA and the genes, and they lose their way. They can grow more rapidly and forget to die and accumulate. So that's just a little review. And then they can invade and travel to other parts of the body to set up camp. Next slide. We thought we'd just talk a little bit about some terminology and words that you often hear. So oncology is really the study and care for people who have solid tumor cancers that start in any of the body organs or tissues. The most common tumors are breast, prostate, lung, and colorectal cancers. Hematology is the study of disorders of the blood or lymphatic system, such as leukemia, lymphoma, multiple myeloma. Next slide. Most cancers will form some type of a lump, a tumor, or a growth, but not all lumps or tumors are cancer. Some lumps are not cancer that are called benign. Lumps that are cancer are called malignant. Some cancers like leukemia, a cancer of the blood cells, don't create an actual lump. They're just cells, and they affect the cells in our blood. Okay, next slide. So what causes cancer? What causes good cells to turn into bad characters and bad cells? There are many factors that contribute to cells turning bad or turning to cancer. Lifestyle habits, genes you get from your parents, being exposed to cancer-causing agents, carcinogens, and the environment can all play a role. Many times there's no obvious cause or reason. Us humans like a reason, and sometimes there just isn't. As we age, we become more susceptible to things going wrong. Our bodies can't always prepare things as easily, or we can sometimes develop cancers. Our immune system is just much more robust when we're younger. Well, when we become more susceptible to things going wrong, Sometimes we're more susceptible, I guess, to those things going wrong when we might have other things going on, such as we're getting older. We might have a number of health conditions that can weaken our immune system and our overall bodies. Some types of cancers run in certain families, hereditary, but most cancers are not clearly linked to genes we inherit from our parents. Inherited mutations are thought to cause only a very small fraction of cancers. Acquired mutations are much more common than inherited mutations. Most cancers are caused by these acquired mutations, something that has happened over time to allow the development of that cancer to start and grow. Some types of cancer are affected by the very hormones that help our bodies develop and function and stay strong. Like for females, progesterone and estrogen helps our bodies in so many different ways. But when we have a breast cancer that has developed that is affected by these hormones or facilitated by these hormones now, those breast cancers have receptors that attach to the estrogen and progesterone, which helps them now grow. So now we have to find a way to block our ability of that body to utilize that estrogen to grow that cancer. So then many of the cancer therapies we have for hormonal cancers might be something that blocks that ability of those cells to take in that estrogen or to stop the production of the estrogen and progesterone. Fluctuations in the balance of estrogen and progesterone can cause changes in our endometrium, which is the lining of the uterus. And, a disease or condition that increases the amount of estrogen, but not the level of progesterone in your body, can increase maybe the risk of endometrial cancer. The same thing happens for prostate cancer. Most prostate cancers rely on testosterone to help them to grow. So then we have to find ways to block or stop the ability of that body to have access to that testosterone. Treatments that stop these hormones from attaching to these receptors are called hormone or endocrine therapy themselves. Stops the ability of that cancer to have access to those hormones, stops the body from producing those hormones. Some diseases and some treatments can leave us also just immunocompromised and more susceptible or at a higher risk for getting cancer. Sometimes if we've had something like a transplant, like kidney transplant or blood and marrow transplant, or we've had a lot of treatment for cancer before, it can make us more susceptible. These are internal factors that can create our bodies to have a higher risk for getting cancer. And then I'm going to turn it over to Gina, who will talk about external factors.
Thanks, Janine. So as Janine covered the internal factors, as she said, I'm going to cover the environmental factors. So we know from research that there are a few things that may contribute to developing cancer. Some of those are environmental factors, which include diet. For instance, if we intake too much fat in our diet, too little fiber, or high amounts of nitrates from processed foods, these all may impact our cells. Substances can also have an effect on our cells. So epidemiologic research shows that people who use both alcohol and tobacco have a much greater risk of developing cancers of the oral cavity, pharynx, larynx, and esophagus compared to people who use either alcohol or tobacco alone. In fact, for oral and pharyngeal cancers, the risks associated with using both alcohol and tobacco are multiplicative, meaning they are greater than would be expected from adding the individual risks associated with alcohol and tobacco together. So we know also for viruses, HPV and HIV, and then for radiation, exposure to sun and radiation therapy can increase your risk in developing cancer. And then occupational exposure. So for example, farmers who have worked with pesticides and or carpenters who have worked with asbestos may be at greater risk. So cancer can start almost anywhere in the body. There are 4 different categories. There's carcinomas, sarcomas, lymphomas, and leukemias. So carcinomas are the most common type of cancer, which arise from the cells that cover external and internal body surfaces. Lung, breast, and colon are the most common cancers of this type in the United States. Sarcomas are cancers arising from cells found in the supporting tissues of the body, such as bone, cartilage, fat, connective tissue, and muscle. Lymphomas are cancers that arise in the lymph nodes and tissues of the body's immune system. And leukemias are cancers of the immature blood cells that grow in the bone marrow and tend to accumulate in large numbers in the bloodstream. So there are a variety of technical names to distinguish the many types of carcinomas, sarcomas, lymphomas, and leukemias. In general, these names are created by using different Latin prefixes that stand for the location where the cancer began its unchecked growth. For example, the prefix osteo means bone. So a cancer arising in bone is called an osteosarcoma. Similarly, the prefix adeno means gland. So a cancer of gland cells is called adenocarcinoma. For example, a breast adenocarcinoma. So metastasis. Metastasis most commonly develop when cancer cells break away from the main tumor and enter the bloodstream or lymphatic system. These systems carry fluids throughout the body. Essentially, this means that the cancer cells can travel from the original tumor and form new tumors when they settle and grow in a different part of the body. The cancer that is spread to the another area is given the same name as its original cancer. For example, a lung cancer that spreads to the bone is called metastatic lung cancer, not bone cancer. So this can be really confusing. This is because the cancer started in the lung and the treatment is used for lung cancer.
All right, so cancer staging is important to note when it comes to treatment. The physicians gather specified information based upon diagnostics, including imaging and specimen collections to make the determination of the cancer stage. The slide here shows that they determine the stage of the cancer, which is based upon tumor size, if there's any involvement of the lymph nodes, and if there's spread to any of the other organs. So after cancer has been diagnosed, doctors ask the following 3 questions to determine how far this disease has progressed. So number 1, how large is the tumor and how deeply has it invaded any of the surrounding tissues? The second would be, have the cancer cells spread to regional lymph nodes? Or has the cancer spread, metastasized to other regions of the body? Based on the answers to these questions, the cancer is assigned a stage. Patients' chances for survival are better when the cancer is detected at a lower stage, like shown here at a stage 0. So clinical grading, this is a physical assessment or an examination by a cancer specialist or a provider, looking for some of the traits associated with your type of cancer that you're being evaluated for. This is more of a clinical judgment staging by the provider to determine next steps in gathering the best results and diagnosing and treating the cancer. This grading will more than likely change once the actual confirmed pathology of the specimens have been collected and analyzed. So to further expand on that, it's the pathological grading, which is the more of a microscopic examination that provides information regarding the likely behavior of a tumor and its responsiveness to treatment. These are done from specimens that are collected during a surgical procedure that can be either extensive or small, such as a needle biopsy. But we also want to express that, not all disease types are graded or staged the same way. So cancers are have a highly abnormal cell appearance. The large numbers of dividing cells tend to grow more quickly, spread to other organs more frequently, and be less responsive to therapy than cancers whose cells have a more normal appearance. So based on these differences in microscopic appearance, doctors assign a numerical grade to most cancers. So in this grading system, a low number grade, grade 1 or 2, refers to cancers with fewer abnormalities than those with higher numbers like a grade 3 or 4. So based on microscopic appearance, the cancer cells pathologists commonly describe tumor grade by the 4 degrees of severity. So the grade 1, 2, 3, or 4. So the grade 1 tumors resemble normal cells and tend to grow and multiply slowly. So a grade 1, they're generally considered the least aggressive. So conversely, the cells of a grade 3 or 4 tumor do not look like normal cells of the same type. They tend to grow rapidly and spread faster than tumors of a lower grade. So grade 1 being more normal and grade 4 being most abnormal.
All right, so I'm going to talk about early detection and screening. So how is cancer found? Cancer can be detected in a variety of different tests that are available. Many of these tests are applicable to multiple types of cancer, such as having your blood drawn, doing an imaging like a CT scan, which we'll talk about in the next slide, and doing a biopsy, where a sample of the patient's tissue is taken from the body and examined by a pathologist, who is a special type of doctor that specializes in studying diseases. However, there are many other different types of disease-specific tests that are widely used. For example, in breast cancer, a mammogram is a part of the regular screening process when looking for breast cancer. Another example is for cervical cancer. In this cancer, a pap smear is usually done in conjunction with the HPV test, as HPV can also cause cervical cancer. Typically, this is recommended for women ages 21 to 65. For colon cancer, a colonoscopy is part of the standard of care, where the doctor looks for certain growths in the colon called polyps, which have the potential to cause cancer. It's usually recommended that people get a colonoscopy every 10 years or so. And then lastly, we have prostate cancer. For prostate cancer, a PSA test is commonly done in the screening stage. This is where protein produced by the prostate gland is measured in the blood. Next, we'll talk a little bit about high risk. So screening for patients at a high risk of cancer depends on a couple of different factors. One of the biggest factors is family history. For example, a female might have a family history of having genetic mutations, which puts her at a higher risk for breast cancer. A good example of this is the BRCA1 and BRCA2 mutations. Another main factor for people getting at a higher risk of cancer is exposure. So for example, if someone received a high amount of radiation exposure as a child, that increases their risk for cancer recurrence as they get older. Now, I do want to point out that if your risk for cancer treatment is higher than normal, then the standard screening routines mentioned above are going to change. For example, if you are at an increased risk for colon cancer, then the screening recommendation to have a colonoscopy may go from every 10 years to every 5 years. And then lastly, in this slide, we do have a link to the American Cancer Society timeline for different cancer screenings, which gives accurate recommendations. We'll be putting this in the chat box, and it will be made available to everybody once the webinar is finished. Next slide. All right, so the next part here is we're going to talk a little bit about the different types of scans that you'll see in cancer detection. So an ultrasound is a very type of scan that's done for cancer screening. This is when we're using non-ionizing radiation to detect cancer through high-frequency sound waves. An example of this is having a breast ultrasound. Another common scan is a CT scan. A CT scan is taking a cross-section or a virtual slice of the patient in order to detect cancer. An example of this being used in cancer detection is for lung cancer. Next, we have a PET scan. This is a type of scan that uses radioactive sugar to detect certain hotspots in the body. This is especially helpful in detecting cancer metastasis to other areas of the body. Often this is done in conjunction with a CT scan. Hence, this is called a PET-CT. Next, we have an MRI. An MRI uses non-ionizing radiation via magnets to create a cross-section of a patient. This is commonly done for brain cancer and soft tissue sarcomas. And then lastly, we have a bone scan. This can be used to detect any sort of cancer that started in the bones, like an osteosarcoma, or any type of cancer that metastasized or spread to the bones.
Sorry, I had to get my mute button off. So now just talking about how cancer is treated. Usually the oncologist, hematologist, in combination with often a surgeon or radiation oncologist will choose a type of treatment, a dose, how it's given and schedule for how often it's given based on the type of cancer, where it is, how big it is, the stage and grade that the person's overall health and age. Cancer treatments work by removing, interrupting, and stopping the growth of cancer cells. Different types of therapy do this in different way, and so side effects can vary on all of those different treatments. Surgery is a very common way to be able to remove a part or affected parts of a body that have cancer in that. For example, for breast cancer, depending on the type, the size, the grade, maybe part or all of a breast tissue might be removed. But surgery is not used for all cancers. Chemotherapy is the use of drugs to kill cancer cells and slow their growth. Chemotherapy is systemic therapy, whole body therapy, goes to all of your body cells. It's often given in a vein through, through an IV, or can be given in an injection, infused directly to the area that's affected by the cancer through a pump. It can also be taken by mouth, orally. It can cause side effects based on it can cause side effects based on the cells that might be affected by that chemotherapy. So traditionally, chemotherapy will affect faster dividing cells. It's trying to attack those cancer cells that are dividing quickly. But it will also affect some of our normal cells that are fast growing cells. That's why so many of the chemotherapies can cause people to lose their hair. But not all cells, not all chemotherapy will cause people to lose their hair. Some will cause a thinning, and some don't affect the hair follicles at all. Other cells that can be affected by chemotherapies are cells that line your gastrointestinal tract, because those cells are constantly replacing themselves. They're very, very fast growing cells. So that's why so many of those types of chemotherapy drugs can cause us to feel nauseous or upset tummy or constipation or diarrhea, depending on that type of drug. Fertility cells can be affected. So sometimes people's fertility can be temporarily or permanently damaged. Also, blood cells are affected, especially they look at things like red blood cells, white blood cells, and platelets. So typically when a person gets chemotherapy, those blood counts will drop for a few days, then those cells will plateau, and then those cells replace themselves again. So every single time a person comes in for a new round of chemotherapy, they're going to get a blood sample to check their blood counts and make sure they're okay again before we start that next round of treatment. Many cancer therapy can be done alone, but often it's done in combination with other drugs or other treatments, such as radiation, surgery, targeted therapy, and immunotherapy.
So contrary to what Janine talked about, radiation therapy side effects are going to be site-specific. So for example, if I'm receiving radiation near my neck, I might feel like I have a sore throat. Or if I'm receiving radiation towards my stomach, I might experience some nausea. So for the longest amount of time, photon radiation therapy has kind of been the mainstay of radiation throughout history. And this is when we're using high energy X-ray beams to kill cancer cells. Now, another type of radiation therapy that has been introduced in recent years is called proton therapy, which is a type of treatment we offer here at the Mayo Clinic. This is another type of radiation that possesses different physical properties compared to photon radiation. Proton treatments may be used in a patient's treatment depending upon the location, size, and type of cancer. Next, we have brachytherapy. This is a different type of radiation where a radioactive isotope is inserted into a body cavity to treat cancer. For female patients, this can be done for many different types of gynecological cancers, like cervical or endometrial cancer. For male patients, this is often done with brachytherapy in prostate cancer. Next, we have something called electron therapy. So this is a type of radiation that's used to treat more superficial skin lesions near the skin surface. A great example of this for the cancer being treated is Kaposi sarcoma. And then lastly, we have a very specialized type of treatment called gamma knife. This is a type of radiation that's used to treat very specific tumors in the body. You might hear this called stereotactic radiosurgery, or SRS. One thing that's important to note is that gamma knife is typically only available at larger medical facilities, such as the Mayo Clinic, due to its highly specialized nature.
So I'm going to talk about targeted therapies and immunotherapy. So first, targeted therapies are a type of cancer treatment that target a specific cancer cell, process, or mutation without affecting normal cells. A targeted therapy can be used by itself or in combination with standard chemotherapy, radiation, or surgery. Cancer cells typically have changes in their genes, as we have mentioned previously, that differentiate them from normal cells. Genes are a part of a cell's DNA that tell the cell to do certain things. When a cell has gene changes, it doesn't act like normal cells or as it should. For example, these changes might allow the cell to grow and divide very quickly, which make it a cancer cell. Targeted therapies can block or turn off signals that make cancer cells grow or can signal the cancer cells to destroy themselves. And then immunotherapy is a treatment that uses one's own immune system to fight cancer. It can boost one's immune system or change how the immune system works so it can find and attack cancer cells.
All right, we're just going to talk a little bit about clinical trials and research. So what is research? So in cancer alone, it may provide and involve some aspects of investigating some new approaches to care. So whether being a simple registry, such as donating blood to study it and link it to certain traits, or to a full interventional trial studying new drugs to treat cancer that may otherwise be used to treat a completely different type of cancer. The new approaches vary from prevention, diagnosis, treatment regimens, or even symptom management. So the phases in which these trials are classified depends on the level at which the monitored study has been approved for, considering being a normal standard of care rather than a research trial. So below we have on the slide here, we have included some links if you want to explore if a clinical trial is right for you. We also include these in the chat and they will be available after the webinar. So we hope this presentation was both informative and helped you understand a little bit more about cancer and the amount of information that comes along with it. So we'll leave this last little bit of time for any questions that you may have.
Well, thank you to Tara, Janine, Gina, and Brandon for giving us lots of good information on cancer treatments, how it's been named, and things of that nature. If people have questions, please go ahead and drop them into the chat right now. There were a few websites that were referenced by Brandon and Tara. I did include those in the chat for you. We'll also post those on Mayo Clinic Connect when the webinar is over so that you can access it there. So one question that did come in says, if I have breast cancer that has moved to the lymph nodes, is that considered metastasis?
I don't know if Gina wanted to answer, but I can too.
Yeah, sure, go ahead.
Well, so what oftentimes is that might be considered like a local, or well, when a cancer is started in one spot and it's in one location and hasn't moved anywhere else, that hasn't spread anywhere. But if it's in the lymph nodes just right next to it, or the tissue right next to it, that's sort of a local nearby maybe spread, or lymph nodes nearby, it may be local, or a little bit farther away might be regional. But when it actually spreads or sets up camp, maybe in a fully different organs, such as a liver or lung or something, then that is truly like a metastatic spread that has spread to other parts of the body. Does that make sense? Or I don't know if you have any other suggestions on explaining that. Yeah.
Yeah, I agree. The thing too is if it was found at original diagnosis. So as Janine had said, if it's local, sometimes that's just considered, that will affect your staging. So your staging may be a stage 2 then if it's in your lymph node as well, nearby. But if it was after original diagnosis in a more distinct location, like a further away, then that may be considered metastasis, just kind of depending on when that was originally diagnosed, or your original diagnosis, when that occurred, if that helps clarify at all. So thank you for answering that question. I think I'll just say that we give general answers to questions, but of course, everyone is so individual. So having a good conversation with your provider is always advised because they know you and your medical history. And we're speaking a little bit more in general terms. Another question that came in is there an analysis of the seemingly increase in pancreatic cancer?
Well, there are every cancer that is documented or proven on biopsy positive has to be reported to specific tumor registries within the institution that it was found, but also goes to the state data and also national data. So they keep track of all specific data. I know that specific teams that specialize in pancreatic cancer are always looking at all of those, at all of the factors that might be or could be contributing to an increase or of pancreatic cancer. I can't speak to it specifically, but I think that's maybe a good question you could ask a provider about as well.
I think as Janine said, that they do keep track of that and stats on it, and it does take a long time for them to do an analysis, and they have to gather years and years of data and look at that before they can really start to define specific trends. So it's good that there's people who do that for us so that we can identify different ways to maybe thwart some of the different things that are having an increase. And then certainly what goes along with that is more study on how to treat that and have success for people that have a diagnosis.
Thank you.
Okay, if anybody has any other questions, I encourage you to put them in quickly. If we don't have any more, then we will sign off for the day. So I don't see any more coming in, but want to thank people for joining us today. We appreciate that. And then also want to let you know that we will convert this into a video that you can access on Mayo Clinic Connect. So if you have people that weren't able to see this today that you would like to recommend it to, please share it with them. And again, to follow our cancer education blog so that you can find out about current upcoming webinars that we'll be offering in the future. All right. Thank you to our panelists for speaking today. We wish you well.
Thank you.
Thank you.
Thank you.